I am excited to invite Sarah Mueller to the podcast and also Lauren Hogan. Welcome to the podcast.
Thank you. We're excited to be here.
How and why did you get into the field of physical therapy?
This is Lauren. I can start. I visited my first physical therapist back when I was 12. So I was really active in gymnastics and later track and cross country. And I started getting injured from a really early age. And so I had a lot of foot and ankle issues, and then later on some back issues and things like that. And I was really interested in the healthcare field. And when I found physical therapy and I saw my first physical therapist, I was blown away by how the physical therapist actually joined the patient along the journey and followed up with them on a week-to-week basis and kind of was able to watch them as they progressed throughout their rehabilitation journey. And so as I started thinking about what I wanted to do, that was really appealing for me. And so every year I enjoy what we do a little bit more.
This is Sarah. My story is similar to Lauren's. The timing was just a little bit better. I got injured like my junior year of high school, which is right when you're trying to figure out what you want to do. So I went to physical therapy at that point and was like, oh yeah, I could do this as a career. And it just blossomed from there.
Yeah, it sounds like a prerequisite to have some kind of injury to get into physical therapy. It's like if you go to get an interview and you don't have an injury, they're like, so why do you want to be a therapist?
It's a good recruiting strategy.
For sure.
Because otherwise you can't be a therapist. All right. So when we talk about physical therapy, what is the classic type of problems a physical therapist or conditions that a physical therapist helps somebody with? And part of why I asked that question is because, unfortunately, I'm guessing the chronic overlapping pain conditions isn't the classic type of condition. But what are and I think having that awareness may be why some people may have some frustrations who have tried working with a therapist and hasn't maybe helped. But what is the training really well geared for, at least traditional physical therapy training?
You want to answer that one?
This is Lauren again. Sarah and I actually both teach in one of the entry-level physical therapy programs. We teach over at UW Milwaukee. And when a physical therapist graduates, they're actually a generalist. So they could go out and work in a school-based setting with kids with developmental delays. They could work in an acute care setting with people that are ill and hospitalized. They could work in a skilled nursing facility or traditional outpatient orthopedics. So within the outpatient orthopedic realm, which is where Sarah and I both work, a lot of clinicians are really well trained in seeing kind of acute injuries. So think ankle sprains or post-operative rehab after a total knee replacement or back pain and neck pain and things like that. And a lot of the kind of overlapping pain syndromes, as you talked about, are not super well understood within the physical therapy realm. I will say I think they're becoming gradually more well understood, but then there's kind of a subset of physical therapists that probably have advanced training and a better understanding of some of these conditions. Because I think, as you well know, and as a lot of your patients know, a lot of the time the symptoms are often widespread and can affect multiple different systems. And that can be tricky for clinicians that do not understand these conditions because they seem very discrete and unrelated when in fact there's a lot of overlap between things. So I think a lot of physical therapists that see some of these conditions fell into it somehow or another, either via another diagnosis that they were treating or by seeing some patients that were struggling with some of these conditions and then put it upon themselves to get more advanced training.
And that's really, I think that's where my training started. I had a Stanlow's patient pretty early on in my career, and I did not know what that diagnosis was when they first came to me. And this young girl thought that stretching would cure all of her issues, which is not the case with the hypermobility condition. So it was a lot of me doing my own research then to try to figure out how to best help her. And then once you've seen like one of those subsets of patients, you kind of are just the clinic expert in treating that, which is good and bad, because I think then you get a lot of exposure to those types of individuals and trying to figure out how to help them better.
Yeah. And I think specific things that are probably in the strong expertise and the high success rate or higher success rate is a stereotypical maybe rotator cuff injury that somebody had specific exercises to do.
Mm-hmm.
And it's one area of pain. Not only do physical therapists not have a lot of training, most physicians don't have a lot of training in this area. And that's part of why we do this podcast, to try to help. Hopefully, as more physical therapists and other physicians can learn more, they can help give better care. The chronic overlapping pain syndromes, because they involve multiple organ systems, it can be very frustrating for physical therapists because the typical treatments don't always work the same. It can be maybe human nature to internally blame a patient for not responding and almost going, I don't know if I have any more tools in my toolbox to
Mm-hmm.
offer somebody. Is that often not, hopefully for both of you because you have more awareness, but just within the average physical therapist and their experience working with this group of patients?
A lot of patients that eventually find their ways to our doors and have seen a lot of other physical therapists and have either been discharged really early, where maybe they're starting to feel a little bit better but haven't achieved some of their goals, or they've met with another physical therapist or another healthcare provider that really didn't understand their condition. And I think how this population tends to be a little bit different is a lot of the time, I like to say we're playing the long game, and it's not the same as a rotator cuff repair where I'm going to see that person for a prolonged period of time, probably like 4 to 6 months. For a patient with these more chronic, persistent pain conditions, a lot of the time I'm seeing them longer than that, or maybe I've seen them consistently early on, but then following up with them every 4 weeks or every 6 weeks, and just trying to think about how do we best manage their symptoms long term so that they can live with the best possible quality of life. Ideally, giving them strategies to help their own symptoms, but then allowing us to help and assist as best as we can along the way.
Yeah, it's not one cookie cutter approach fits all. You know, it's the taking kind of the big picture, what the patient goals are, really listening to that patient. And it's not necessarily the same thing every session either. You know, sometimes we build a little bit and then you take two and a half steps forward and 1.5 back. And a lot of physical therapists may not be able to have that flexibility in their treatment plan for what they have in their head as to what the patient should accomplish, which is something that's a little bit more challenging because that doesn't traditionally fit how we were trained in our school to think about patient management. So you're kind of constantly reevaluating, assessing, changing goals. And that's really where you have to have a little bit of a different relationship with the patient to be able to help them along their journey.
When a patient comes to you, what is the presenting diagnosis that you're given? And what percent of the time would you say that their diagnosis of a subacute, acute-ish regional pain isn't a classic nociceptive or tissue damage, but that there's more of a centralized nociplastic pain, more of that central nervous pain? I'm guessing when you are getting the patients, how often have they been told of this as a tissue damage or nociceptive condition, and then you discover that a bigger part of this is more of this nociplastic or centralized pain?
It happens quite a bit. The more imaging and the more special tests a patient has done, if you have an MRI done, something's going to pop up in an MRI, right? It's going to show normal age-related changes, but it may look like degeneration or it may look like a disc issue. But as we're evaluating those patients, a lot of the time their symptoms do not necessarily match up with what is on imaging. And so a lot of the time that can be a tricky conversation with patients, especially if they've heard a lot of different stories from other healthcare providers about what is causing their pain. Different things come to light where you start to notice that there are some other multi-system involvement going on or other areas of persistent pain. And you may be able to start picking that up a little bit. But it can be a really tricky conversation both with the patient and with their other healthcare providers if they are thinking that it's a tissue issue and not a pain issue.
And people get stuck on that. I know I have degeneration of my L5, and they get stuck on that degeneration part of it. And they've been going to physical therapists for years and years and years, right? That's not what's causing your issue. And trying to even talk about the healing spectrum, and we know that tissues heal. So if this is persistent for longer than the average healing time of 6 months to a year, it's a lot of these other systems that are coming into play. So a lot of times we're the first one to tell them that.
And what is the types of reception that a patient has when you're sharing that?
There's a funny saying in the PT world that it depends. Our students always say the correct answer is it depends. And it absolutely does. And I think sometimes a patient is in a good place to hear some of this information and we're able to convey it in a way that it makes sense to them and it fits with their past experience of pain. Sometimes they're not in a very good place to hear this. And it is really tricky and a total mindset shift if you've heard for years or decades that your pain is coming from that disc degeneration. And now there's this physical therapist that's kind of rocking your world a little bit by saying it's actually a pain problem. And it goes back to even being a kid. We learn or we're told from an early age that pain means there's an injury. Pain means there's a tissue injury. And we now know that pain means that the body is feeling some sort of threat, and it could be due to an injury or it could be due to something else. And so that is a big mindset shift. And sometimes somebody is in the right place to start learning more about how their pain works. And sometimes people may need a little bit more time to let that marinate.
Any thoughts on that for you?
The fact of the other therapies that you've tried haven't helped. So let's think outside of the box here and see what else we can do. And pain it's all encompassing. I mean, when these people come in, it's it's in the forefront of their brain. They can't focus on anything else. And I get that. That's a struggle. I feel like that's going to inhibit their progress going forward if they can't focus outside of that pain realm.
Yeah.
That's part of our job is to understand where they're coming from and kind of recognizing that even though we're explaining things with the best science we have available, it's a different paradigm and it's a different thought process. And that's not going to change overnight. And that's oftentimes why this is also tends to be a little bit of a longer plan of care. And maybe people are going to be, checking in with us on a more regular basis or for a more prolonged period of time.
That is part of why I wrote my book and started with a 2-page handout, then a 20-page handout, because it's when you have that conversation, it's really not a quick conversation, and you have to have a paradigm shift of your understanding, which is you're saying that all of these orthos, PM&Rs, injections on my back, 3 spine surgeries have really not addressed the major problem. And there's this other process going on, and that is a new concept. And that's why hearing your side of this as somebody who wants to help be a kindred spirit and recognizing a need for a more comprehensive understanding, because so much is with education. And when you look at a patient, can you maybe think of a patient that might come in commonly that fits this mold? And what were some things that might key you in specifically? I don't know if anything comes to your mind, or a patient that you can maybe share an example of.
Yeah, I mean, I think, even if a client comes in with just generalized knee pain, getting to talk to them more and trying to figure out, last year it was their shoulder, or 2 years ago it was their back, and then their ankle. And they also have some maybe GI related concerns, or others like migraines, other systems that kind of tie into that hypersensitized nervous system. So once you start asking the right questions, you can see why these are either frequent flyers to physical therapy, or they never really healed from their first go of physical therapy. And then just drawing the patient's attention to, like, some of this stuff is all connected, and it's trying to regulate your nervous system to actually help with the healing process compared to the tissue issue.
Yeah,
Yeah.
I like that tissue issue. We think of in oncology, tissue's the issue until we get that biopsy back. We don't know if you have cancer or not. Tissue's the issue, but now tissue issue. Is it a tissue issue or not? So when you look at one of the questions is what is important for patients to understand, if you had a chance to share when it's a much more clear nociplastic component, a centralized pain component where it's not a significant tissue injury, or maybe they have some arthritis, maybe they're 60 and they have some arthritis in their knee, but not severe enough to require a knee replacement. What is important for those who are going through this type of pain to know? What do you share with them when you have that time?
I think one of the biggest things, and I would say this is the case for anybody with pain, but to understand that pain is an output and not an input. And so it is an output from the brain. If you sprain your ankle, your brain is still the output creating your pain sensation. And also, especially with our nociplastic pain, we need to think about it that way as well. The brain is getting information and it is deciding without not intentionally deciding, but it's trying to figure out if whatever information it's getting is a threat. And sometimes it makes the right decision and it either alerts us of pain or not pain. My caveat here, or at least one thing I always want to say, and I always pause here as I'm explaining these things, is I think a lot of patients that have persistent pain start to think that, oh, you're just saying that's all in my head then. And that's not what we're saying at all. What we're saying is the brain is what is producing pain in all situations. Your pain is real. But if we understand that the brain is perhaps over responding to certain stimuli, then we can start tapping into some of those stimuli. And I think about it as sort of recalibrating the system a little bit. We have to figure out what you can tolerate right now and do a little bit more, a little bit more, a little bit more, so that system doesn't over respond or overreact to that activity. And that's a tricky concept. And I think we need to be really careful as physical therapists in how we explain these things, because the last thing I want a patient to think is that I think they're making up symptoms or they're exaggerating symptoms. No, we know that pain is real. We know that the pain that you're experiencing in that situation is real. It just may be working a little bit differently than we often think, or we often have learned pain.
We all have this low grade energy that lets us know we're alive. So if you think about it, we get this like static on the television. Your nervous system is this low grade sound machine that's just in the back helping you relax. But when your nervous system is dysregulated or too active or too overcome by pain, it turns into like the horror film static on the television, or the sound machine is way too loud and it's all encompassing and the only thing you can think of. So our goal with graded activity and exercise and other modalities is to help calm down that nervous system response, to kind of bring that sound machine down to that lowest level, just that lets you know that you're alive and that everything is kind of, all systems are go, everything's running smoothly.
Yeah, they have, the brain is so complicated, and that description is that salience network where normal sensations become to the level of irritation. And for many people, that can be noticing their bra strap is just pressure. Somebody else is on accident. It shouldn't hurt. The tag shouldn't be uncomfortable, but your body is bringing that hypervigilance. It can be a good thing in some ways if you're a soldier out in the battle and trying to hear the twig snap and be ready to react. But when you're in a safe area and there is no threat, pain, kind of adding that definition of a threat or perceived or real tissue damage. And that is a concept that makes up a lot of pain. And these are overlapping. I hope to do an episode just on breaking down these newer words that are changing to help describe these situations with the nociceptic, neuropathic, and the nociplastic type pain. When you are working then with patients who have a nociplastic pain type condition, what are specific type strategies that helps this type of patients, this type of people who are listening more so to tie in?
I think one of the strategies I would use is to start with one variable and kind of work your way up, or try not to add too many variables at once. If we think of a realistic goal of being able to wash your dishes, then we have to start with modulating your activity to be able to tolerate that. And then the next day, reevaluate and see how you did. So we can't muddy the waters with too many different things to start with. We kind of have to start with one thing, start working your way up, but consistency is really key. If we're trying to assess your tolerance to something, if it's too much one day and you're laying in bed all day the next day, that's not helping your nervous system regulate that pain very well. So it's really a touch and go, kind of trying to figure out how to bridge that gap between activities that you can do and still having the energy to get through the rest of the day and the next day.
Absolutely. I think about it sometimes as we want to, I have a friend who uses the term, you want to touch or tease the pain a little bit. I think a lot of the time, patients that have been in pain, and especially high levels of pain or persistent pain for a long period of time, they often do one of two things. They either don't do anything because they don't want to be in pain, or they are so used to living in pain, they're like, I just have to do this anyway. And so we'll call that kind of the boom bust cycle. Like, you just overdo it. And then, like Sarah said, they crash for a few days afterward. But instead, we want to kind of touch and tease the pain maybe just a little bit. And what happens with the nervous system, or at least the way we best understand it, is all of a sudden the nervous system realizes, that was a little bit of a challenge, but it wasn't too bad. I tolerated it okay. So the sensitivity starts to go down a little bit. And so if we're constantly, we're challenging ourselves just to that point before really flaring things up, all of a sudden that hypervigilance, as you talked about, starts to slowly decrease, or that static starts to decrease. We're turning the volume down. And then, so that's kind of our graded exposure approach. And then, as Sarah had mentioned earlier, I think our treatments really vary. There are some people that do fantastically well with manual therapy or dry needling, so we may incorporate some of that. I have some people where, allodynia or hypersensitivity to something like manual therapy may cause more pain. So in that case, we're going to do something different. I think when we can find ways of doing exercise, that's helpful. So it's finding what helps us calm the nervous system down and then start progressing forward. And that's going to look a little bit different for everyone. The other thing we also know is there's some good research to back up just the more patients truly understand their pain, it's effective in helping to reduce their fear associated with their pain. And oftentimes their pain levels start to decrease as well. So I think I speak for Sarah and myself that we really make sure that our patients kind of understand, what does nociplastic pain mean and how is it different than our
traditional acute injury.
Yeah, yes.
Yeah, nociceptive pain or tissue damage.
Yeah. All of a sudden, I second guess myself. I'm like, did I say nociplastic or nociceptive?
I had to. I looked on my website and I had nociceptive on my website when I meant nociplastic. So these are newer words that I think in the last just couple years, more shifting from that centralized pain syndrome, which used to be many years ago psychosomatic, and now we're having much better. And all the research is looking at, actually, we can see within the brain processes pain differently by looking at functional MRI imaging supporting this. So it's a real, which is neat to share. For many patients, I think what you're touching on is that locus of control is not, they haven't had any. Can you speak to that in your experience with going through this?
I think you're right on that. And because when you don't understand how some of these conditions are working, sometimes the symptoms seem so random and so discrete, where it seems like, I don't understand why today I couldn't do dishes. I could do dishes last year and I just can't do these things now. And so when you don't understand how or why pain might be elevated one day versus another, that does feel like a loss of control. And when we start to see that happen, it oftentimes leads to more fear and avoiding activities, which leads to deconditioning, which kind of creates this kind of vicious cycle of fear avoidance, and it makes things more challenging. And so when patients understand their pain better, they usually fear it less, and that gives them a little bit more control over their conditions. It's still challenging for sure, but when we can restore that, a sense of control, or at least a sense of understanding, I think it makes a huge difference.
I think too, the education part of empowering patients to take control of their healthcare is one thing. The paradigm has shifted a little bit in that instead of just taking what your primary care physician says as like the gold standard, or like, you have knee pain because of this, patients are actually thinking about maybe what else could be potentially causing that. It's trying to empower them to kind of take control of their healthcare a little bit too, and not just follow along the path of, these are your goals and this is how we're going to get you there. But how can you be more active in helping you get to your goals? What motivates you to want to do these exercises that I'm prescribing if they don't make any sense? So I think the empowering the patient too, and letting them kind of take a little bit more ownership over their healthcare is really important.
Just thinking that for many primary care doctors, they're referring somebody because it's a checkbox and get out of the office. They're not experts on this, and they don't know what else to offer, and their toolbox of prescribing a medications may be limited. So let's try something. And also recognizing for these types of conditions, it's much more than just a exercise of a specific body part, but it's what happens outside, and also little keys to the pain. Well, I didn't notice it when I was engaged in doing something I enjoy. Maybe they play the piano or music or something. Well, how could it miraculously go away? Or something stressful happens and I felt more pain. That's consistent, right? When you start to maybe log and have that exercising, and sometimes there may be a lot of situations that are going on. What about the role of pacing? I think you kind of touched that kind of touching the pain. I'm assuming that involves also pacing. Are there any ways that self-monitoring beyond the traditional exercise, how many rotator cuffs and bicep curls have you done, or for your shoulder, which is very traditional physical therapy, right?
Yeah, I think the no pain, no gain thing is really not the type of physical therapy we prescribe anymore. So self-monitoring, we definitely don't want you, when we talk about teasing the pain a little bit, we don't want you to go beyond that threshold of where, because you did 800 bicep curls, you think that the next day you're going to be able to lift your arms again. So I think it's different for everybody as far as the pacing and prescription is. I don't know if there's a certain way. Try to think of a patient example.
I think there's a little bit of trial and error for patients as well. And so as they start to understand their own bodies, I'm thinking about one of my patients in particular. I think all of our patients are going to overdo it sometimes. And then, they might have a rough day or two afterwards. But we could get really down about that, or we could learn something from it. And we're like, okay, you overdid it because you had X, Y, and Z that day, or you just really wanted to we keep going back to the dishes, but you really wanted to get all those dishes done. So we learned that was maybe a little bit too much. So let's kind of scale it back a little bit. One of the tricky things about some of these pain conditions like chronic fatigue syndrome, sometimes it's kind of the delayed increase in pain. So in the moment, they may not notice that they overdid it, but may notice it. I have a patient that usually notices it a day or two after. So that can be tricky to catch. I think there's some interesting research coming out about kind of tracking heart rate, like when they wake, like resting heart rate when they wake up in the morning, and kind of figuring out what state or heart rate variability. But I think kind of assessing where a patient is at that day, figuring out what they need to do, and then taking appropriate breaks so that they are breaking things like chores or other activities up into small bursts and taking enough recovery time in between. They can often accomplish a lot more that way. I often will start out with underdoing it a little bit and then start building from there, because I find if I overprescribe activity and then I do flare them up on day 1 or visit 2 or something like that, a lot of the time can be hard to
recover from that. And it can be as simple as just setting the microwave timer when you're doing dishes for 5 minutes. That 5-minute timer hits, all right, you need to move on for a couple more minutes and do something else. It's listening to a song. That song is what you get for wiping off your countertops, and then take a break and do something else for a bit.
Do you recommend, or how often do you use step counters at all, or activity monitors? Is this part of this?
I think I'm going to go back to our favorite response. It depends. So I think some patients are really motivated by it, and it may be a nice way to either do graded activity exposure where, okay, right now your baseline is you're at 2,000 steps a day or whatever, let's slowly build from there. Or it's also can be a nice way to be like, oh, I had a really rough day yesterday, and then I noticed I did 5,000 more steps than usual. So I think it can be a nice way to track progress and maybe get some insight on what may have caused an increase in symptoms. I think some people can get a little bit too
hyper aware.
So in that case, I will scale it back and not think about it or not use it quite as much. But what is nice is a lot of people walk around with their phones, and our phones are tracking all sorts of interesting stuff. So sometimes you can tap into the data and get some interesting info without a lot of work. So it can be helpful, especially if somebody has like the goal to increase activity and things like that.
Yeah, I think I tend to more rely on like a time frame than steps, but
yeah. It's one of those where you have to know where somebody's at. For those who have that, recognizing how much they can do in a close of exercise prescription, assuming somebody doesn't have severe osteoarthritis in their knees or severe spinal stenosis, where traditional exercise of walking is hampered. That's going to be a challenge. Of course, if they're on a stationary bike, I may not get credit for that, and what the intensity is and how do you quantify that. And for many, I'll say for a week, track your steps. Most may not have had it. Just see where your steps are. It's rare that I have somebody when they track for a week, or if we look back just on their Apple Watch or whatever, their steps, the graph of their daily steps is like a roller coaster. And they go, oh, well, I didn't do much for a couple of days. Then I overdid it. Then I felt bad, so I didn't do much. And then I felt bad, so then I overdid it.
Yep.
And then I felt bad. And then you go through the cycle, and if you're like, hey, you have to pace yourself and see where your average is, and then gradually increase that. Just like somebody running a marathon, their friend's been training and can run 9 miles on a long run on a Saturday, they're not going to be able to walk a mile, and they're going to be feeling terrible, but they don't even know where their it is. And it's better, I think, often to spread it out over a day than to do it all at once, especially when you're at a very low level to start with.
Yes, absolutely.
Short bursts frequently versus one long burst.
I got a chance to interview someone living with Ehlers-Danlos on my podcast, and he made a major change in his life and struggled with a lot of substance use issues and just was very heavy, obese, overweight, and he was motivated because of cancer in his mom and mother-in-law, and both had died, and he was having high blood pressure, etc. And he made a comment, well, I decided and realized that if I move, I'm in pain. If I don't move, I'm in pain. Well, I might as well move and also give up those other substances, and was motivated to incorporate that. When there's a special group of patients, and I know I've talked to you, Sarah, and maybe both have a lot of experience with this, but a real challenging group of patients can be working with people who have POTS. Can you talk about what are the special challenges with somebody living with that, and strategies for getting better, and that can be involving or awareness of a heart rate?
Definitely awareness of kind of a heart rate, blood pressure response, but you don't want to focus too much on that either, because then that tends to take that sensitive nervous system and maybe increase the anxiety of that, which then can increase those kind of vital responses as well. Yeah, there's a couple of general guidelines that I usually follow for those types of patients. And then it's a lot of education in trying to have them take ownership over some of the stuff, because you can't be there all day long to help regulate how they're doing from supine to sitting and sitting to standing. And it's the consistency of being upright, I think, throughout the day that's initially the most challenging aspect for those people, and just kind of building from that. I think, again, you can't really take a protocol and apply it to every situation, and everyone's responses a little bit differently. So having the guideline of, yes, this is normal, and especially with POTS and some of those other dysregulation of the nervous system conditions, you're not necessarily going to respond textbook style right away. So it's trying to educate along with, these are traditionally how you should be feeling. And yes, we're going to have good days, we're going to have bad days. Like Lauren said, we can't see you one session and then miraculously you're cured of your POTS. It doesn't work that way.
Yeah, I used the phrase before, kind of recalibrating the system. And for some reason with POTS and some of our other autonomic conditions, the nervous system is just not responding how it's quote unquote supposed to. And so what we need to do is we need to slowly challenge it. And so that it learns that things like sitting up are okay, and that the nervous system can tolerate it and respond in a more quote unquote normal manner. And so but it, like Sarah said, it's not going to be a consistent process. It may kind of vary along the way, but we know that typically as we gradually challenge somebody a little bit more, we start to see some of those improvements. But I think a lot of it is the understanding and the education. So patients fear those responses less. Can we calm the nervous system down? Because we know the nervous system is reacting in this way. What we want to do is quiet some of our reaction to it if possible. So it's only getting overactivated a certain amount. Controlling what we can control. How about that?
And just getting patients to realize that they're not going to be like this for forever. This isn't something that is going to limit them for the rest of their lives. It's maybe something that they have to be a little bit aware of, and they might have flare-ups here and there, but it's something that's very manageable.
And the cool thing about the nervous system is the more we learn, we realize that it's neuroplastic and that it is trainable and it learns and it So a lot of these things are really challenging because patients have been experiencing pain for a very long time. But we do know that the nervous system continues to change based on the demands we place on it. And so a lot of people who've had pain for a really long time, we can make some really good changes.
What impact is it for your patients to share that you take care of a lot of patients who are going through similar struggles?
I think oftentimes when you first start out as a PT in your first couple of years, you kind of have this idea in mind of how you're going to have an initial evaluation. You're going to talk to your patient a little bit, and then you're going to do some hands-on, and then you're going to do some exercise, and then they're going to feel better and go home for the day. And I think for a lot of our patients with more complex presentations or nociplastic type pain presentations, a lot of the time the first day, they are just telling me their story. And if they have the time to really explain their story, sometimes we are the first people who've had the time to listen to the whole story and put some of those pieces together. And so for us, I think it's really helpful to get that background, because not only do we hear their whole story, but we hear about how they feel about their pain. And we hear about things that haven't worked. If certain things in physical therapy haven't worked in the past, I'm going to do something else. And so a lot of the time I get a lot more out of that session by just sitting there and listening. Most patients, unfortunately, haven't had that experience where somebody is just sitting there listening to their story for a full hour. There used to be, having somebody poke and prod them and do tests and things like that, and then they leave in more pain. So I think also when we've seen a lot of patients with kind of these complex multi-system involvement conditions, I think a lot of patients are used to people looking at them funny because they're like, well, I have all these GI issues and I have migraines and I have this and I have that. And it seems like a lot of different conditions, but instead we're thinking about it more as related conditions.
And I think too, the kind of stigma that they've maybe gotten from other healthcare professionals when they come in and start talking about their pain is that maybe they cut them off from telling their full story, or they are seen as like these problem patients that just come in and whine the whole session, which is not. To get the full story, you really do, you need to have that time to listen. And I do way less special testing if I can sit there and subjectively actively listen to the patient for a longer time, which then also makes their pain less because I'm not purposely putting them in positions that I know are going to be painful. So it's a lot of the listening, the guiding, and a lot of subsequent sessions may be more like that too. It's not necessarily, physical therapy isn't the cookie cutter approach when it comes to this type of situation. It's a very fluid, moving session. So sometimes we just may focus on breathing that session, or education on how we're going to get through going to the grocery store later that day. Did we answer your question?
Yeah, no. I find as I'm doing this is I will have that 5-second pause, because within 5 seconds you'll get another thought, and then I will talk at the same time you do. And then it's hard to edit out that combined. So I had some quote on some 3-star review said, "Oh, he let the guy talk really long, but when he had that woman on, he didn't get to talk as long." So I'm trying to just give a question and then let you guys talk. I'm trying to be the good podcast, NPR podcast host. One of the tools that I've talked about on the podcast and share with my patients, because these are often long histories, it's much more than my brother-in-law who is skiing and does the once a year skiing in his 40s and going down the mountain and does that last jump and then just landed and I felt the pop and there goes the ACL. It's very clean cut, the basketball player running down the court plants and pulls his ACL or sprains, they're very classic, or even often rotator cuff injuries where there's a very clear cut history. We were both being interviewed about whether naturopathy was true, and she had gotten out of it because she thought it was a lot of taking advantage of patients, selling a lot of supplements and other things that weren't necessary, and that, was a lot of useless care, so to speak. And I said, well, I wouldn't criticize yourself too much because there is a lot to have. I wouldn't criticize you too much because you actually listen to them for 45 minutes or an hour when that nobody else has done that. And there's 20-30% of just having somebody who cares. Now, to take a special supplement and to say that you have some mold infection in your body or have some yeast infection that has to be flushed out and here's a special protocol and is not the answer, but actually listening and then the correct solution. Often that falls in the world of functional medicine where at least they're listening and then they're trying to get that simple solution. You need to take your fish oil plus the niacin tablets plus your coenzyme Q to get the mitochondria working when at least they're listening. In one of the things I'll do with or encourage my patients to do if I have an initial visit, like you may have, and then you only have so much time, right? But actually say, hey, can you write down your story going back to childhood? And, I'd say maybe in 5-year increments, what was your first 5 years like? And next, and go to wherever they are now. And you're 63 years old, it may be a 7, 8, 9 page. At a recent patient broke the record of 7, went to 9 pages printed out. If they can gather their thoughts and the fact that I wanted to actually hear her story and what are the strengths, what are the struggles, what kind of high stress situations, and you'll find that there is a lot also of abuse and trauma that are involved that nobody would even know that happened that was around that time. Just talking to a kind of a relative, not by blood, but talking about IBS and migraines and how it started at age 18 when my grandma died. And it also might have been I went off to college, other changes. I think you getting a chance to hear their story is part of that. And I think we call that, hopefully you're teaching with your students, that therapeutic alliance, right? It starts with that trust.
Absolutely. I think this is the same across like the medical professions, but we usually say by the time you're done talking to them and taking a subjective history, you should have at least an 80%. You should be 80% confident you know what's going on. And I think with a lot of the patients that we're talking about today, it should be even higher than that. And that's worth taking the time and getting to, and it's going to set the stage for the rest of our rehabilitation relationship. But you're exactly right. In day one, you want to start figuring out what is going on. But I think our priority should be building that relationship and building that therapeutic alliance, because that will get us much further long term.
And I would bet that you have patients of yours who it's an emotional relationship response, probably some tears that you get at your sessions that the average physical therapist probably never had.
Yeah, I would say yes, which is that's okay. And I feel like 80% of patients that maybe start becoming tearful during a therapy session are like embarrassed by it, which it's really important. That's an important part of what we're here to do and how we're going to help you. And I don't ever want patients to feel embarrassed by sharing that with me. And like Lauren said, we're a team. We need to be able to build that rapport to be able to get the patient to their full potential.
Yeah, we know that pain is an emotional experience. And I think that's particularly true for people with persistent pain. It's the reason we have tissues in here. It's been a running joke at my last few clinics that my room is the place people come to cry. And it's not because of what we're doing in terms of exercise or hands-on treatment. It's usually while we're sitting in the chair talking. And it's important to start to realize the impact pain has on emotions and vice versa. You should never feel embarrassed by big feelings coming up in a PT session. It usually means we're making progress, or at least starting to figure out some things.
They trust you and that they can unmask around you. Many people who are dealing with chronic pain syndromes are neurodivergent, whether that's on the autism spectrum or having ADHD, and much of their life is walking around masking. And now they're unmasking and sharing, and because they are probably coming to you guarded on how much they can truly share about the distress they're going through, because this 35-year-old woman is acting like she's an old woman based on how much pain. So I can't even admit, or I'm afraid to admit. Otherwise, I'll be stereotyped or stigmatized.
And how much energy is that person using all day to hide those things? And, how is that impacting their pain experience?
There's often that incorporated a history. I have a recent patient of mine who had the fibromyalgia impact score goes from 0 to 100. Her score was 98. Been through so many doctors, were referred by our primary after being through many other doctors' pain clinics, and now we're working on things. Turned out she did have some coexisting ADHD and some neurodivergence with that. We're addressing that also with education and having that hope. And she's had some tears, and just a recent follow-up, I said to her, I got a feeling you're almost not wanting to jinx yourself about how good you're doing now with gradually doing more. And she's like, well, yeah, this has been so long, probably since before menopause, that she was having this. But what she said to me, and this is kind of getting to another topic, she said, my grandma, I remember taking her to the doctors, and they would say, you can only talk about one part of your body. You can't talk about all of the different parts of your body. You can only complain about one part of your body. For those who are listening, both covered their mouth and shook their heads. What kind of thoughts do you have when you hear that?
That's still the old school method of physical therapy treatment. Is you come in, I can only address this specific, your diagnosis was knee pain, I can't address anything else. And there's like nothing that's more frustrating. Having someone then come to me after going to a couple of physical therapists that have done that, and it's a totally different approach, right? Like, you don't even have to have a diagnosis to come see me. Like, we can just figure it out from where you're at. And I'm sure Lauren's on the same boat with.
I actually get a lot of questions from my students who are like, if that person comes in for knee pain, am I allowed to look at their back? And I'm like, well, are you going to get them better if you don't look at some of these things? And honestly, some of it is like institutional limitations for clinicians that work out of either hospital systems or other clinic settings where they're told that they have to look at things in a very small, like just at the knee or whatever. And sometimes insurance companies also put a limit on things, which can be really frustrating for this population. I think that's on us. It goes back to taking a really good history. And when we start to notice on day one that this is much more than a patient with knee pain, more widespread pain, we have to do a little bit of work on, if we need to, getting a script, or we need to document appropriately that there are other body parts and regions or conditions involved, so that we're not limited to one specific area, because we're not going to get very far if that's the approach we take with a lot of these patients.
And the patients aren't going to get better, and then they're going to get frustrated anytime they get referral back to physical therapy.
Yeah. And I think it's really tough sometimes because a lot of patients a lot of patients who've been in pain for a long time have seen a lot of physical therapists, and they've been in more pain, or they have found that it didn't work, or they found that somebody didn't spend very much time with them. And sometimes they come in our doors and they're like, whoa, this is different, right? And they start feeling like they make progress, which is awesome. But I also feel very bad for the patients that have lost hope in PT. It's not going to help me.
I've tried it before.
Or all PT looks the same. They're just going to make me ride the bike and do leg lifts.
This is a group that has a lot of despair. They've seen many doctors. And I think even getting into this world as a physician who is addressing this in a comprehensive, holistic, evidence-based way is, and now trying to amplify that message so more people can hear about that and get the help they need. But it's the relief and grief, the relief that they're improving, but the grief that, what if I would have had this addressed, and how come you seem to put it together and nobody else does? And that's where you get a chance, just like I do, to connect with physical therapists in training, and we'll have that little seed in their brain that this group of patients exists, and probably phone calls as they get years down the road talking about this group and knowing like, oh my goodness, I saw my patient and I thought about what you told me in the lecture, and I had that connection, and it turned out there was so much else going on in life. And I just asked, I mean, now for physical therapy, you have to get a doctorate, which means you have a lot more training, which means you're on that diagnosis potentially, where versus delivering a therapy, and it's incorporating this, and like you say, having that confidence to say there's that nociplastic. One topic that I wanted to maybe end with was, what are your thoughts on prevention of these types of pain conditions? Because my patient who is 62, who her grandma had issues, and often there's a strong family history, right? Or maybe 50% up to that inheritance, environment, and other things that can play a role, and identifying and helping. So what are strategies? So when I think about somebody who may have an injury, classic tissue injury, which may trigger a chronic pain condition, what are your thoughts, or just in general, trying to prevent the development of these conditions, maybe starting younger?
Yeah, we were discussing this a little bit before too, with just trying to really be more proactive with these. And it's more of like, if this was a family history, kind of getting the family members involved too in your care, and trying to recognize some of those early signs and symptoms. If maybe it started out as an acute injury, but it's persisted longer than it should have. So what else do we need to look at here? What are we missing in your family history? Are there other autoimmune conditions present? Are there chronic pain? What are we missing as far as why this injury is taking so long to heal? And then being proactive from there on out, and really setting the base for how to help with these types of long-term solutions to manage these chronic pain type issues. And that's where I love treating a lot of family members and incorporating family into the treatment sessions as well. I think that support is really important for anybody that's going through a chronic pain condition.
Absolutely. And I think younger people, when they start presenting with some signs, a lot of the time it's not quite as widespread as people that have been experiencing pain for a longer period. So I think we can start making informed changes from an earlier age to hopefully prevent the severity or intensity of pain from increasing. And even if sometimes it's just tweaks to their strength. If they play sports, like, can we tweak your strengthening program for sports? I want these people to stay active. And so if we can figure out a way at a young age that they stay active instead of stopping these activities, I think that's important. I also really educate people a lot that I want you to come in before something's a big problem. So we're going to go over strategies. And if your pain starts to increase again, I want you to try your strategies first. But if your pain is severe or it's sticking around more than a couple of days, like, come on in and let's troubleshoot this. People, for some reason, don't want to bother us or something. And I'm like, I would much rather help you when it's a little problem versus, when it's been going on for a longer period of time. You're miserable and it may take us longer to address it. So don't ever hesitate to reach out to us, even with an email or a phone call or something, or pop in for a visit, and let's try to fix this, or at least manage it before it becomes a big problem. The other thing that I think Sarah kind of touched on about getting the family involved in a lot of cases, and because they seem so odd, where it's affecting GI and migraines and all of this other stuff, it is really hard for family members to wrap their heads around. And so the patient might be able to start explaining things, but oftentimes we can be helpful in educating the family members so they have a better understanding, instead of it just being kind of this nebulous diagnosis or diagnoses that don't make a lot of sense.
In the family, they really want to help, they just don't know how. So they either end up almost enabling in providing that negative feedback, or they're more frustrated, and then the patient doesn't want to say anything because they don't want to inconvenience their family member with another migraine or another doctor's appointment or another issue. So it's really it's kind of opening up that line of education for everyone to be able to get everyone to kind of see the bigger picture
and be on the same page.
Yeah, that's part of the audience, hopefully, for the podcast are the family and loved ones who are listening who don't have a brain and nervous system that work this way, but to understand there's a lot of people out there who are struggling with this, often invisibly, not sharing, don't want to be perceived as a hypochondriac. Often we're stigmatized, and often the family is left with, you've been all these doctors, you've been all these therapists, and they're not helping. The natural thought is, are you a hypochondriac? You know, and blaming the patient, and that just creates this hopeless cycle. But with a comprehensive approach of, you can improve or lessen, because I do both primary care and have a special interest in this area as well, and clinical lipidology and diabetes prevention. I found out at a young age that I was on a path towards likely having a cardiovascular event in my life. High risk cholesterol panels, inherited some cholesterol related factors, also a high genetic risk for developing diabetes. Well, if I know that at age 33 and address that, I need to take a cholesterol medicine, a statin, and eating a healthy whole food plant-based diet, and keeping active. For most, and I'm curious what your experience is, most of my patients who have chronic pain syndromes were very active at some point earlier in their life. When that tails off, whether that's middle school, high school, college, their first child, any comments on what your experience is with that?
Yeah, that holds very true with the type of clients that we see. People say, like, when I was in my 20s, I used to run marathons, and now this is where I'm at. And then they're almost hyper focused on I was so active, and how come I'm not anymore? It's really like that one, not necessarily the one stressor, one input of like, I then sprained my ankle and couldn't get back, or there was like some sort of negative stimulus that you can tie a lot of stuff back to.
And it's hard for somebody who identifies with being very active, either as, in their youth or in their 20s, like they're used to being athletic. They're used to probably pushing through some pain, but what we have to start helping them figure out is where they're at right now. How can we start where we're at and get you where you want to go? But a lot of those people are the people that are used to pushing through some sort of discomfort from whatever sports they've done. But the pain or the discomfort that they're feeling now is more of that nociplastic type pain instead of nociceptive type pain. And so it's like meeting that person where they are and helping them understand where they are. And then how do we build from there without a lot of fear or judgment on their end, like self-judgment, I think sometimes. And that can be one more challenging aspect.
And I think it's that more, I think of it as your body is probably wired to function better being more active than the average person. Using the word exercise is like a bad tasting medicine, but being more active, that's whether that's gardening, walking, dancing in the living room for 20 minutes to at whatever pace, whatever you enjoy doing, that your body needs that more than the average person. Now, right now we're trying to get out of the quicksand. We're trying to get out of the whirlpool, getting sucked down. But if we can get up to that and then recognize your body needs that as a maintenance more than that, just like my body needs a healthier whole food plant-based diet much more than somebody who has inherited genetics where they can eat no vegetables and fruit and have better cholesterol than mine. Everybody's different. It's interesting when we talk about POTS. I have a couple patients of mine who are likely on the autism spectrum, but both are high-level athletes and both have some nociplastic pain, but not diffuse. And now I'm recognizing that both are competing. A 100-mile bike ride. One of my patients went on, and she and her husband were training together for this. It wasn't just a one weekend, we're going to go push it, and was doing all the training and said, my heart rate will get up to like 190, but my husband, we're doing the same thing, and he only gets to 140. And now I recognize it was another patient of mine who swam competitively in high level in college. he'd say, oh, when we had to do these workouts, I could easily get my heart rate up. And now I'm like, well, the more we know, that person has an autonomic nervous system that is much more reactive. Now, when they have a throw in a life event, a stressor, and or a acute injury, and now that body is also hyper responsive. So these are keys within somebody's history that they're more prone. So if you do have painful periods, that may be more that you need to keep active no matter what you do. And if you're walking around in college and working out, but somehow after you have to continue to do that, it's therapeutic as a lifetime, and you'll feel better. But, and that's again getting that locus of control. How do we get back up? Not feel bad that we aren't there, like we caused this. But if you can, when I work with all ages as both a pediatrician and an internist, is I see a 25-year-old woman who finally gets this after many years, but finally gets this understanding, finally gets it. I said, so when you have a daughter someday, are you going to keep this all quiet and then pop it on her because this was such a good learning and it's just worth going through all this, versus sharing that from the get-go? And it's like, oh, sharing that from the get-go and recognize, like, Mom, you sure every day always have to get that walk in the evening, no matter what the weather is. You always got that hour walk. And then as they get farther along, well, you and I we go for walks, and that's just something that we had. Now, your great grandma, she always used to complain of pain all of the time. And grandma had some, but I learned this in my 20s, and now you're getting a chance to learn about this from the get-go. And unfortunately, we can have a lot of medications that are taken up very quickly, with all these new diabetes medicines that help with weight loss. But integrating this complicated approach is a slow uptake, because the earlier you can get this, right? If the earlier I can treat my high cholesterol and diabetes risk, the better it is than waiting until somebody has a heart attack at 55, waiting until somebody has diffuse pain throughout their body.
Yes, absolutely.
Any last thoughts to share for, I guess, we have hopefully the three types of listeners: those who are living with this, their loved ones, and also for clinicians caring for this complicated patient population that may not have had much training, but are at least open to learn.
Absolutely. I think that's the thing where I think we've seen a lot of patients make really big strides that, have maybe started out being very minimally active in a lot of pain. And when we start to think about that nervous system as being hypersensitive, like we think about all of the different strategies that we have to kind of quiet that nervous system down. There are some people that are going to require a little bit more sleep. There are some people that are going to require a little bit more of like a plant-based or a whole foods diet that is a little less inflammatory. There are a lot of people, and I think the upcoming generation of physical therapists, at least if we have anything to say about it, they're going to be a lot more knowledgeable about how to treat patients that are presenting with more chronic persistent pain conditions, and hopefully can provide more relief for patients that have been struggling through this.
Sounds good. Thank you again. I will have the links to your practice. You're in the Milwaukee area. So for those of you who are in Europe or California, Maryland, it's probably too far of a drive. Can you do virtual visits with physical therapy? I know in the world of psychology, they do that. And I don't know if you've ever even entertained doing this. Do you ever do any out-of-state virtual work or even in-state virtual work?
Yeah, we would be more than willing to talk to people via email. There's some logistics with virtual visits and license.
Sure.
And
so you don't, it's similar to medicine where you have to be licensed. The world of psychology, I think there are a lot of states that have allowed access without going through the hassle of applying for licenses within multiple states. That's the same problem for a doctor, is you have to go through all the state medical boards. But if you're in the area and you want to get connected with somebody who gets what you're going through, who understands it and wants to work with you and help, they are great to connect with.
Thank you.
Thank you so much for having us. And we really appreciate all the work that you're doing to bring a lot of knowledge and insight and hope to a population that's been historically very underserved.
Awesome.
I should have kept with my maiden name.
What was your maiden name? Wasn't Goodland.
No, it wasn't Goodland, and my maiden name was Bellin, which
Okay.
everyone recognizes up in Green Bay.
So you're part of a very wealthy family of some
There's
kind, no?
no relationship that I got any money out of. So, but just name recognition.
What is the role of journaling with maybe helping people track things?
Yeah. So one of my clients right now, she has POTS and fibromyalgia and a couple other things too, but basically kind of just sends me updated logs as to what her activity levels are during the day, how she's feeling, if she kind of gets she has been getting this crash at like 5 to 6 p.m. So we're trying to work on a little bit of activity modification to avoid that crash at the end of the day. So she's just kind of emailing me logs, or people can journal in a notebook too, just so they can kind of look back and see if there's certain correlations with their activity levels and kind of what happens in the next day, day after that. And then also to look back and see like, wow, 3 weeks ago, I wasn't even doing 10 minutes of activity, and now I'm up to 30 minutes on a bike. So it's really cool to kind of draw people's attention to that, especially if they're really struggling and can't see that kind of long-term goal yet. Just to say, hey, we're like 30% of the way up the mountain here. You're doing great. Here's where you were a couple of weeks ago. This is where we're headed. We're right on track. So it's just a nice way for people to really end result in their progress along the way.
It's really hard when you're in the moment of a long recovery, because you're with yourself minute to minute and day to day. For us as physical therapists, we're often seeing people once or twice a week. We're going to see bigger changes on that once or twice a week span or longer. Having those reminders or being able to look back at it makes a big difference when it's starting to feel like this rehab process is taking a long time, because we have a little bit of almost like rehabilitation amnesia along the way. And that is very common in, across rehabilitation, being all sorts of injuries or other conditions as well.
And for many people, it's the first time they've ever gone through anything like this in their life. So they don't have they've never personally had to go through and never had to climb slowly back up a mountain. So it can seem hopeless in their small changes. So for me, I use a fibromyalgia impact questionnaire, a widespread pain and symptom severity score, to help monitor, because you often have a partial improvement. There isn't a score going from 98 out of 100, which is extreme, to 20, which is, I think, kind of 20 or less is in more normal range. That doesn't happen overnight. So if you have an intervention and they go from a 98 to an 80, they still are in a lot of struggle.
Just to even allow people to be aware of their progress that way, it's a little bit more showing more objective improvements than what they day to day are even feeling.
And there may be a step back, but then like, wait a minute, that's understandable. Some event may be had, there may have been some added stress. Okay, how do I try to get through that? And a patient of mine who gets COVID, and then she's 3-4 weeks later, like, I'm tired, I'm exhausted. Can you run some labs? But this is an ultra marathon runner type, runs a business, very active, probably neurodivergent, but aware, and has a job and lifestyles that adapt. And I'm like, hey, you're more prone to get long COVID. Don't let yourself drop too low. Try to maintain a decent base here, and then gradually get back up. And then you come back 6 months later. Hey, how are you doing? Oh, I'm fine. Yeah, just for a month or so. But there's a fear. Rest. You mentioned earlier, no pain, no gain. I think of that in a reverse situation. I never went off the field for football and developed a stress fracture. And we had a sign that said no pain, no gain. You can get a stress fracture that if you keep running on it. That was a nociceptive pain. And by the time basketball tryouts came, I had to sit out for 6 weeks because it wasn't bad enough that I couldn't play, but I couldn't play 100%. So hindsight 2020, I ended up being a doctor, didn't go to professional sports, and I wouldn't have made a difference. But it is that challenge when you're trying to differentiate between tissue damage and these, and they can seem different. Often one of those things would be, when is the pain? When do you notice it? Well, I noticed it when I was sitting. Okay, pain that occurs worse with sitting is not likely a mechanical cause. It may be, well, I was worrying, I was thinking, I'm stressed. It went away when I played the piano versus, or went away when I went for a walk. When I have somebody who has atypical nociplastic chest pain that overlaps with that anxiety, and say, go for a walk. If I think they're relatively low risk, if I think they're having a heart attack, call 911. But you can get from a history if it's like that, and you're like, oh, okay, it actually feels better when I got outside and I was going for a walk, and well, I hadn't exercised in a couple of days, and I was feeling overwhelmed and stressed and work, and then my kids are having struggles, and I was just feeling tense, and okay.
I woke up and had to do some deep breathing and go for a walk.
You weren't worried about the podcast, were you?
Oh yeah, I was.
Oh no. Okay.
I have a lot of performance anxiety, so this has been
hey, you faced fear.
It's all low grade exposure.
Like I say, it's nice just having conversations, knowing you're helping people, but also knowing that you're, hey, I'm human too, and going through this, and that we don't live in a perfect world where there is things that are out of control, and having that support, getting that family in there. And sometimes the inverse happens, where family comes in and they're not supportive, and the spouse doesn't get it, and or they may be making things worse, and you're like, holy cow, there's a lot going on here. I think you guys did an awesome job, and like I say, my first physical therapist on the podcast. I have an interview with an occupational therapist that I'm doing in middle of April. The concept that I found that she talks about is interoception. It's just that hyper awareness of things, and she talks about some of the chronic pain issues. What's funny is because she wouldn't necessarily be chronic pain, but she's talking about a concept that applies, is that hypervigilance, hyper awareness often occurs in that neurodivergent spectrum, that hypersalience of normal things. That, how do I know I'm hungry? How do I know I'm full? How, all of that. So just having a conversation with trying to get a broad understanding of concepts. And so that's what she's talking about. And all of these overlap, just to reinforce.
That's going to be a really interesting conversation, because I've actually thought about it more. I learned about it with kids, and because a lot of the OTs in the kids world and emotional regulation and things like that. But I thought about some of our patients, if they're either over or under interoception, and how that might have an effect on pain.
Yeah.
So that's really interesting.
No, I heard her talk, and I'm like, well, I'm going to bring that in. And she's like, well, why do you want me to be on a fibro podcast? Because you don't know this, but that overlaps. And then having an insight, oh, no wonder my body and nervous system, that hyper responsive. Just having conversation and topics. Do you have any topics that or any comments, if you've listened to any of the podcasts, any value?
Super. The few that I've listened to have been really insightful. We listened to the one about he was a Ironman athlete or an ultramarathoner?
The one who had Ehlers Danlos, Tim Kaufman.
And it is really just interesting about how people find themselves. It's kind of there's an addiction component to people that end up in ultra sports. And, I think a lot of people find the same for chronic pain conditions. Mm-hmm. So it was fun to hear his journey and, how hard he's worked to get where he's at.
Yeah.
Yeah. It's also somewhat sad too, because he has to push so hard, yet his joints don't work, where the person who doesn't have Ehlers-Danlos, who's 25, 30, 40, doesn't have early joint disruption. And I'm like, oh my gosh, I feel bad when he, quote, can't, and he's never going to go back on opioids again. And it's inspirational. Mm-hmm. And when you hear those stories, but also hearing stories of people who are struggling, but like our patient who has POTS, is getting somebody on to share that journey. Here I am, here's a journal, and having them write the story of, and for the people who think, well, I didn't think, and Tim talked a bit about some of those, all of the out there saying, well, how you did all these things. No, this is where I was. I couldn't even get out of a chair. Mm-hmm. And I broke a chair, and then you got one step, and that's that mindset. Well, if I can do this, I can do this, I can do this. And next thing you know, but it was that motivation, but he found it, you were encouraging, and both doing that. I'll definitely share this with you guys. I think it'll be coming out in April. I'll send a link to that. And like I said,
Thank you so much for having us. We really
Yeah.
appreciate it.
all right, take care.
Thanks.
Bye-bye.
Have a good one.
Thank you.